As mentioned, a topic is polio to COVID-19, lessons from the past for the future. It was mentioned, I do have a book out, so this is a bit of a financial conflict of interest, and I just want to acknowledge that I do have research funding for unrelated work from various organizations. Okay, so this is really an origin story and also a celebration of where we come from, and it's a happy story. And I love origin stories. Marvel Comics has figured out that we all love origin stories. Things like Captain America, how did this man turn into this man? And so similarly, we can ask the question, how did we get from wards that look like this in hospitals to wards or ICUs that look like this? And of course, this is a long, drawn out process in some ways, but in other ways, there's these sort of transformative moments, and I think they're useful to learn about. I want to start out with a quote. As an intern in 1952, we admitted patients with AMI wherever bed was available on the medical service, but always as far from the nurse's station as possible, so they would not be disturbed by the commotion, especially the frequent telephone ringing. It was not uncommon for me when arriving on the medical floor at 6 a.m. to draw blood to be sent for testing to discover that one of my AMI patients had died quietly during the night. Older physicians accepted this as just the way it was. So this is 1952, so this is a little over 70 years ago, not that long ago, certainly within the lifetime of people we all know. And to recognize that really it was a completely different construct for what could be done for people in the hospital in terms of care. And just to sort of summarize, there was no invasive mechanical ventilation available. Oxygen was through mask or tents. There were no blood gases. There were a few antibiotics, but not a lot. There were no ICUs as we know them. And there was lots of a disease that we actually, luckily, have not had to take care of, which was poliomyelitis. Now, just a quick primer on polio, because people don't think about it too much anymore. It's an enterovirus, meaning it's oral fecal in terms of transmission. And it's actually quite similar to COVID-19 in some ways, in that the majority of people who contract it do not show any symptoms. Asymptomatic transmission, you've had it, you don't know it. I guess one difference was that once you'd had it, you had pretty good immunity to polio, whereas we know that sort of is not necessarily the case for COVID. If you did get it, again, the symptoms that you generally got were the kind of non-specific childhood illness or general symptoms, fever, nausea, lethargy, etc. And these would come and go in a few days. But if you were unlucky, about 5% of people on average who got polio, the virus would hit the spinal nerves and cause paralysis, often of arms or legs. And so there was the kind of classic images of children in braces or needing crutches. And the paralysis sometimes dissipated, but sometimes stayed. And again, a bit like COVID and long COVID, we never quite knew who was going to end up with residual paralysis. Now, the worst forms of polio were, of course, when it hit the respiratory muscles in the spinal column that caused people to have difficulty breathing. And the absolute worst version was when it hit the bulbar nerves that controlled things like swallowing, because, of course, then people literally sort of drowned in their secretions they couldn't clear. And that was a tiny, tiny percentage of patients, but bulbar polio had about a 90 to 100% mortality. Now, from 1928 onwards, polio really became synonymous with the iron lung, which really is our first form of life support, our first machine that can keep people alive who have an organ failure. And this was a real breakthrough. Now, this is a really famous image of sort of in the United States where they had lots of iron lungs. Just as a side note, although people think that this is them taking care of patients on a ward, it's not. This was actually the auditorium at the hospital, and they were having an assembly, and they actually brought all the patients together to participate. But this is the image that people have in their heads of the care of polio patients. And just as a quick primer, because I realize everybody here is probably all involved in critical care, but not everybody thinks about the iron lung very much. And so it was this, tube that sealed everybody in at the neck and created this pressure inside that you could create. You could suck the pressure out or the air out and create negative pressure in the tube. And so it would literally suck the chest wall open, and therefore the lungs would go with it. Air would rush in through the mouth, the trachea, into the lungs, which is essentially the way we breathe, right? It's physiologic in that when our diaphragm pushes down and our muscles pull out, it's the exact same thing. It was just the machine doing it instead of the paralyzed muscles. So incredibly effective for basic respiratory paralysis, incredibly ineffective for bulbar polio, because you can imagine pooling secretions in the back of the throat, suck the lungs open, suck those secretions into the lungs, 90 to 100% mortality, even with the iron lung. But it was very helpful for lesser forms of paralysis. So by the early 1950s, what you have is that, focus on use of iron lungs or polio in the middle there. You also had a lot of other things that were coming down the pipeline. Up in the upper left there is all the resuscitation medicine and shock treatment that people learned, particularly in World War II. On the bottom left, the use of acute dialysis. Oops, that wasn't quite supposed to happen yet. Acute dialysis on the bottom left in the Korean War. On the upper right, Walter Dandy was famous for creating a kind of neurosurgical care unit with the idea of having expertise of nursing in one place. And on the bottom right, you have some of the very early ventilators that were starting to be developed for use just in the operating room. And just in a few countries, the Swedes had a few, there were a few in the United States, but it far and away, I would say 99% of operating rooms still operated with someone hand ventilating the patient if they needed ventilatory support. And what you didn't have yet was this idea of bringing all of these different concepts together at all for the care of patients. They were all very separate and siloed in terms of these ideas. So then the story shifts in 1952 to Denmark and specifically to Copenhagen. And there they had one hospital, was the infectious disease hospital for the city, the BLEGDAM hospital. And they'd seen a fair amount of polio there over the years, but what they had never seen was a major epidemic. And because of this, they had one iron lung and 6 what are called cuirass respirators, which is basically a mini version of iron lung that straps over the chest and sucks the chest open, and you can imagine isn't particularly effective except in very mild cases. The head of that hospital was a man named Henrik Alexander Lassen, HCA Lassen. He was a very smart man, very driven, very experienced taking care of polio patients over about 20 years. And in fact, he just hosted the prior year in 1951, a giant international polio conference. Jonas Salk was there, Sabin was there, all the big researchers were there, and he knew them and introduced them. And so he was a world expert on the subject. But what he wasn't an expert in was what to do when this happened. In the summer of 1952, they started to admit to the hospital greater than 50 cases a day by the end of August. And most concerning, a much larger proportion than usual of these patients had respiratory failure. And in fact, not just respiratory failure, they had bulbar polio. So they were seeing just a terrible uptick in cases. And unlike the United States, where the epidemiology was that it spiked in the summer and was known as the summer plague, in more northern climates in Scandinavian countries and elsewhere, the polio tended to peak in the autumn. And so they knew September and October were likely going to be much worse than July and August. And you can see they were only starting to see this rev up. And they were losing patients every day. And by the end of August, they'd had a 90% mortality for all the patients with respiratory failure because it was so severe. So they were in really dire straits and nobody quite knew what to do. I mentioned they had one iron lung, but they also kind of knew that bulbar polio was not going to be helped by more iron lungs. So even if they could have gotten them, it wasn't going to be useful. One of Lassen's underlings, and there's a kind of a whole backstory as to how and why he had this idea, a guy named Mogens Bjornbo kept badgering Lassen saying, I think you should try bringing in this guy I know. He's an anesthesiologist across the road. Now, anesthesia at this point in Denmark was barely a specialty. It had literally been recognized for a year as a specialty. There were 5 anesthesiologists in the entire city, and none of them had much recognition. There was no permanent position anywhere for an anesthesiologist. But Lassen, with nothing else to do, agreed to meet Ibsen. And so he was brought in on the 25th of August. And there was a meeting in Lassen's office, and this is not a picture of the actual meeting. We don't have one, but a bunch of people, about 20 people or more, crowded in to the office. And Lassen said to Ibsen, this young kind of outsider guy, what do you know about polio and care of polio patients? And Ibsen's response was basically, nothing. I've never taken care of a polio patient in my life. So to Lassen's credit, he absolutely could have kicked this guy out of his hospital at that point, sort of saying, what can you possibly offer? But instead he said, I'll take you on a tour of the hospital. So he takes them on a tour and he shows them all of these patients with respiratory failure dying of polio. And his explanation for the symptoms he's seeing, tachycardia, hypertension, sweating, is that the brain has been overwhelmed by the virus. The kidneys are overwhelmed by the virus. Their bodies are just shutting down. There's nothing to be done. Now, Ibsen looks at those same patients and he sees something different. He says, I think this is carbon dioxide retention. Now, why, you can sort of say, well, of course it's carbon dioxide retention. We all know that they can't breathe. But it was actually unusual even for an anesthesiologist to have this level of understanding. Why? And why did Ibsen in particular? Well, they happened to have tapped the right man in the entire world to look at these patients, because he'd been playing around in the operating room with a machine called the Brinkmann Carbovisor. He and a colleague, Engel, a thoracic surgeon, had been using this machine, and this entire machine just measures carbon dioxide, end-tidal, and oxygen, nothing else. But he would sit there in the operating room and he would hand ventilate his patients and bag them down and watch the carbon dioxide levels drop. And then he would stop ventilating them and watch the carbon dioxide levels go up. And he also noted the symptoms they had. And when the carbon dioxide level went up, when he stopped ventilating, they were tachycardic and hypertensive and sweaty and uncomfortable looking and confused. And so he put this together and said, I think that's what's going on in your patients here. In fact, he said, I think that what you need to do is ventilate these patients. And he proposed what's called the Waters to-and-fro circuit, a very, very simple circuit that was used in the operating room, where you can see there's a bag that was literally a rubber bag that you squeezed, soda lime, which was used to scavenge and extract the carbon dioxide that someone breathed out, oxygen and nitrogen canister, and a little humidification, and then either an endotracheal tube in the operating room, or what he proposed was to use a tracheostomy. And he said, I think you just need to ventilate your patients. Now, Lassen was a little bit skeptical, and there's an interesting story as to why Ibsen even sort of knew to think about this. He actually had a paper with him from an epidemic in Los Angeles that had proposed this idea. But Lassen had nothing else to try. So he said, okay, I'm going to let you try this on one patient, and I'm going to choose that patient. So, oops, just need to forward my slide. The next day, August 26, 1952, a little girl by the name of VIVI EBERT was admitted to the hospital. She was 12 years old. She's 9 in this photo here. She's a little bit younger. This is the house she lived in Copenhagen with her mother and her grandparents. And she had classic bulbar polio. She was having difficulty swallowing. She had paralysis of a couple of her limbs. And they knew very well the natural course of this disease, right? As I described to you, they'd seen a lot of bulbar polio. They knew it was close to 100% mortality. The very next morning on August 27th, Lassen and his team rounded on her, and she was near death. And he pointed to her and said, try it on her. So they wheeled her into a side room, not a lot of informed consent going on, and they called in the ENT surgeon, they called in Ibsen, and they asked the ENT surgeon to do a tracheostomy, and then Ibsen made a small mistake. He was worried she was so close to death that if he gave her general anesthesia, she would go into an arrest and die. And so he asked the ENT surgeon to do the tracheostomy under local anesthetic, which he did, but he got into some bleeding. So suddenly he had a patient who not only wasn't breathing and hadn't been breathing for quite a long time, but now she was also in bronchospasm from the blood. And remarkably, we have his entire record from when he takes over care after the tracheostomy goes in. He really kind of almost minute by minute, he said, now in a situation where we cannot perform ventilation because of her spasms and agitation. At this point, everybody literally leaves the room to go to lunch, and they do so because they think she's going to die and they don't want to watch. And Ibsen's panicking. It's every anesthesiologist's nightmare. And so he decides that his only chance actually is now to give her general anesthesia despite the concern. And he gets lucky. He administers pentothal and notes about 15 minutes later, the patient is immediately warm and dry. An N of 1 experiment. It's exactly what we say you should never do to try to prove that something works. But everybody came back from lunch. They knew the natural history of this disease. They expected her to be dead. And instead, she was literally awake and interactive and stabilized. He went on to hand ventilate her overnight to show that he could keep her stable. It wasn't, there were some tough moments, but he got her through the night, and Lassen was impressed, and he knew a good thing when he saw it. And he said, right, we're going to do this for every patient who has respiratory failure in this hospital. And he was the right man at the right time because he'd actually grown up kind of an army brat. His father was in the army. He'd grown up on military bases. He knew how to organize people. But there was one problem. I mentioned to you there were a few ventilators in a few operating rooms across the world, but there were no ventilators to wheel into the rooms at the BLEGDAM hospital. And so they had to figure out what to do without ventilators. What did they do? Well, famously, they turned to the medical students of Copenhagen. Initially, they came in the dozens and they put out calls, notices went up, they went into their lectures and beseeched them to come, and they dropped their studies and they came and they sat at the bedside of these patients, hand ventilating in 6 to 8 hour shifts, 24 hours a day. And over the course of the next few months, they stabilized up to 70 patients at a time in the hospital. In all, they went through over 1,200 medical and ultimately dental students as well. As you can see, they not only ventilated them, but they also entertained them because, of course, polio is not a disease that does anything other than impact generally the muscles and the nerves. And so the patients were awake and interactive, and they found all kinds of ways to communicate with them. There's pictures of them, with kind of those boards where you can point to letters, and they use lip reading and they use eye blinking and all the things that we do now to try to communicate with our patients when they're on ventilators. Some of them became very close oops, the wrong direction here, and became lifelong friends. And I got to meet one of the student ventilators. This was Ann Holton Jensen, who became an anesthesiologist because of her experience that year. Unfortunately, she did die about a year ago, but she shared with me her experiences in the hospital. So this led very quickly to the recognition that they needed mechanical students, and that's literally what they called them at first. And there was an explosion in development of these. Everybody kind of got in on the act. There were some Danish manufacturers, Swedish manufacturers, ultimately US and everybody else. And this is really the start of interest in ensuring that there was access to mechanical ventilators. The other important piece that came out of this very quickly was this question of what was going on in the blood. And they had one measurement they were able to make with the kind of crude laboratory stuff that they had. And that was a measure of total bicarbonate in the blood. And they'd measured this. And they understood that if the bicarbonate level was very low, this was a metabolic acidosis. And they extrapolated that if the total bicarbonate was very high, this was a metabolic alkalosis. What they didn't understand was they were measuring both the carbon dioxide and the bicarbonate in the blood, not just the one. And they had no concept that there was a respiratory component to what they were seeing in the blood. Ibsen came along and he said, no, the carbon dioxide is super high in these patients. I think if you actually could measure the pH in the blood, you would find it's really acidotic, not alkalotic. Now, this was taken up by one man who was in the room by the name of Paul ASTRUP. He was sitting in on that very first meeting on August 25th. He was the head of the laboratory services. And he said it was like a light bulb went off when Ibsen says this. He literally said, we just didn't think about carbon dioxide. And once Ibsen had explained it, he realized that Ibsen was right. And he really wanted to check what was the pH of the blood, but he'd never been able to measure the pH of the blood because they didn't have a pH monitor available. But he knew who did. Down the road was a company called Radiometer AS, and they had manufactured a pH monitor for Carlsberg Brewery in order to measure the pH of beer. And so he called them up and asked if this would work with blood and whether he could borrow one of their machines. And so they wheeled it over, and within 2 days of Ibsen's first demonstration on VIVI EBERT, he had checked the pH of the blood. And this was really one of the first tests that was done to even measure this. They just extrapolated that they thought it was alkalotic. And of course, Ibsen was correct. It was incredibly acidotic, not quite lemon juice, but certainly, very different from what was the received wisdom. And so he recognized that if they were going to be ventilating patients, that there was this direct relationship between the carbon dioxide in the blood and how fast they were ventilating and what was a safe range, and that they needed this to help guide the care. And he wrote later that by January 1st, 1953, they'd done 705 determinations of pH. This is really the first use of blood gas analysis in the care of patients. And he created a system that allowed you to kind of do it, not in real time, but fast enough that you could make use of that information clinically. And for many years in Scandinavian countries, people would say they needed an ASTRUP, not a blood gas, because it was so tightly entwined with him and his expertise in this area. So by the end of the epidemic, which actually didn't tail off until sort of December, January, February, they'd gone from 87% mortality to about 36% mortality midway through, and then all the way down to about 11% mortality by the end. I mean, it was really miraculous, and really it's something they'd never seen before, and it had been done on hundreds of patients. So they had good data, I mean, not RCT level data, but pretty good data to suggest that this worked. I do want to pause, and so at this point, the mechanical students took over and the regular students went back to their studies. And I do want to recognize, though, embedded in these numbers, of course, are a lot who didn't survive. And for the students who took part, it was, of course, exhilarating and exciting to be part of saving all of these lives, but it was also incredibly traumatic. A lot of them left, devastated by the deaths that they'd experienced, and they'd gotten quite close to some of these patients. One of them was a man named Flemming Balstrup. He was a student at the time, and he shared, not with me because he's already died, but with a prior researcher, his experience. He went back to his studies, he said, and he was in a fog. He was proud of what he'd done, but he was really struggling. He said he took a holiday to try to sort of recover. He went skiing on his own, and then he shared with people what he experienced. He said he was at dinner with people. He said, I said little during the meal, concentrating on eating. I would occasionally return conversation, but rarely took the lead. As the dessert was served, one of the other guests unexpectedly cracked a bawdy joke. After a momentary embarrassed pause, all in the room roared with laughter, none more so than myself. It seemed that a safety valve had opened, and suddenly I felt able to cast off my reserve. But as I laughed, the tears started to flow, and the laugh slowly changed into cries. Heart-wrenching, soulful wails. At first unnoticed, gradually one by one, the diners stopped laughing until the whole table went silent and stared at me, their mouths open. I buried my head in my hands, and at last the cries and mourning and tears for the children came. And I felt it important to include this description because I think it will resonate with everybody on this call who experienced the care of COVID patients, because I think that for many people, are still struggling with what they experienced, and that, for all the celebration of COVID is quote over or we've moved on, those who were in the midst of it don't move on that easily, and that this is a universal. However, life did move on. And for Ibsen, he finally got a job, a kind of permanent position at the municipal hospital, which was the public hospital. And he was an anesthesiologist there, but kind of had a fair amount of freedom to do what he wanted. And he had witnessed what had happened, once they implemented his techniques in the polio epidemic. He'd also witnessed kind of what was needed for the care of these patients. And initially, he set up a post-operative recovery room in these windows here that was open during the daytime. But by the end of 1953, he had created what he really wanted to create, which was the first modern intensive care unit. He extrapolated the care that he'd seen, and what did he have? He had a dedicated area, which he recognized you needed from caring for the polio patients, 24/7 staffing, frequency of vitals and monitoring, something he took from the operating room, blood gas analysis that came from the polio epidemic, invasive mechanical ventilation from the polio epidemic, other organ support that was coming down the line, such as dialysis and vasopressors, specialized nursing, which he also recognized from the polio epidemic. And then this was the kind of vision piece beyond that, in blue here, the care for a range of patients, that you could use mechanical ventilation, not just for polio patients, but for care of a whole range of patients. And suddenly you have something that looks like what we would recognize absolutely as modern intensive care. So December 1953 really marks the start of that. This then spread pretty quickly as people realized this was a good thing. By 1958, you got the first ICUs in North America. Peter Saffer in Baltimore, who actually wrote about how they knew what had happened at the BLEGDAM hospital in Copenhagen, and that this was really important for the decision to set up an ICU. Max Harry Weil on the West Coast in LA, and then up in Toronto, Barry Fairley at Toronto General Hospital is one of the founders, the first ICU there, and he's still alive out in San Diego, and happy to talk about his experience setting that up. It's a really interesting story. So what did we learn from polio? Well, positive pressure ventilation, blood gases, respiratory physiology. John West, the physiologist, writes about how there was this renaissance after the polio epidemic as people realized the importance of studying it. ICUs as we know them, and then a lot of other things that I just want to highlight briefly because I'm not talking in depth about them, but rehabilitation medicine, a lot of it came out of the polio epidemic as they recognized they needed to support people in the rehab process. Disability rights, a lot of the advocates for disability rights were polio survivors who had physical disabilities. Of course, vaccine development, and then I'm going to touch on at the end here the long-term sequelae of viral illness. If you do need an advertisement for vaccination, this is it. This is US cases of polio. The vaccine came in 1955, and you can see the blue is the cases, the red is deaths, just this precipitous drop after 1955. Really remarkable. And of course, we've had a few blips since then, but certainly compared to the number of cases they were seeing, that highest peak is actually 1952 when they saw over 50,000 cases in the United States. Now, what have we seen since then in terms of infectious diseases? Well, we've certainly had our share, you know, I probably don't have everything on here, but these are the ones that kind of came to mind as the kind of big blips, of course, culminating in COVID-19. And I just want to highlight a couple things that I think we've sort of learned along the way. I view SARS as really it was the wake-up call. There'd been a few influenza epidemics before then, but this is really the first epidemic that occurs in the era where a lot of ICUs exist in the world. It was very scary. I know I wasn't here in Toronto when it happened, but I understand, you know, that it was pretty terrifying. And it was a recognition that we needed to start knowing what we could do for patients and what our bed availability was. And in particular, in Canada, Rob Fowler, my colleague here at Sunnybrook, led a study to understand just critical care capacity. And this is really the start of recognizing that we needed to build up our understanding and be ready. And the other epidemic that I actually want to highlight is the Ebola epidemic, which I realize in some ways didn't touch people who cared for patients in most modern ICUs, but I think has a key lesson in it. And the Ebola epidemic in West Africa in 2014 led to a lot of healthcare workers going in to try to help. And unfortunately, some of them did get Ebola and were often able to be airlifted out. And so they received care in centers that did not have expertise in Ebola. Nobody had expertise in Ebola, but that had modern critical care. And there's this remarkable table in this work led by Alex Neilipovitz, where she tallied, the outcomes for all of those who receive care in kind of high-income countries with modern critical care. And if you look at the right-hand column, survived, survived, died, survived, 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 died. This does not read the way you expect based on the data coming out of West Africa about Ebola, where it ranged anywhere from about 40 to 90%. It was down to about 40% with sort of better, more specialized central care, but still was quite high. And this, in comparison, was 18%. Again, still not zero, but I think it's one of our best modern examples of how just modern critical care works, right? To have access to that care does give you actually data which looks a lot like Lassen's data from the intervention of mechanical ventilation for polio in terms of the drop in mortality. And to me, this just highlights something that I think is the main takeaway from sort of all of these epidemics, including COVID, which is do what we do and do it well. That we have more gadgets than Ibsen had back in 1953, but fundamentally, it is that multidisciplinary, coordinated, good critical care basics that we do best that really leads to the best results that we have so far. Okay, I just want to end by talking about one last thing, which I think is something about sort of for the future, which is a long-term sequelae of viral illness. Just to give you a story, this was Robert Krauss. He was a member of the Blue Jackets, this band in 1948. He's on the drums there in this slightly fuzzy picture. And a few years later, he actually developed polio. And he was in the United States in New Jersey. He was in an iron lung for about 6 months and then recovered and went on to become a professor of psychology at Columbia University. And there, he had led a normal life. He had no more respiratory issues until a number of years ago when he started to develop post-polio syndrome. And I learned about him because there was a New York Times wedding announcement for his son. And during COVID, his son got married on an aircraft carrier that was moored in Harlem on the Hudson River. And they'd chosen that site. First of all, they needed an outdoor space because it was COVID, but it was not the most romantic site, but they'd chosen it because the carrier happened to be moored under the window of his parents' apartment. And so his father, Bob Krause, was now back on a ventilator at home and was unable to really leave the house comfortably, and was able to watch this event take place below him on the deck of the aircraft carrier and participate in that way. And I just thought that was a kind of a remarkable story of kind of ingenuity, but also highlighted the struggle of many of the polio survivors, which is that most of them, particularly the ones who have had pretty severe polio in the first place, are developing post-polio syndrome. And this is something you may see caring for patients in the ICU now if you haven't already. So it was first reported in 1962. You had to have survivors who lived long enough. And it really seems to hit people at least 15 years after they've recovered, but usually 30, 40, 50 years. Weakness, fatigue, pain, functional loss. And we don't have great estimates on what percentage of patients get it, because depending on your denominator, it's very unclear. So people who had kind of mild polio, they think are less likely to get it than those who had severe polio. Those who had residual paralysis may be more likely to have further deterioration. But it's pretty devastating. These are people who have spent their life recovering function and working to recover function, being told that if you just keep working, it will get better. And then all of a sudden, actually, it's a bit like, long COVID and all of these other diseases where if they push it too hard, it actually makes it worse. And so it's a total change in mindset for them to have to find that sweet spot of still stretching and doing exercises to try to maintain function, but without overdoing it. And so there's a lot of parallels with, kind of chronic fatigue syndrome and other things like that. For those who are interested, there is a nice review article that was done in 2000. So, now probably a little bit out of date, but on post-polio syndrome. And for critical care providers, it's relevant because if someone's had polio and they're deteriorating, something to think about is whether or not what you're seeing with kind of increasing weakness or needing a ventilator for sort of unclear causes, that this can be post-polio syndrome. The problem is it's a diagnosis of exclusion, so we don't have an actual test for it. There are some theories about why it happens. The overriding concept is that motor neurons get hit in polio and some of them die. And then other motor neurons try to, as much as possible, take over the function. And so people who recover some function, basically the remaining motor neurons are taking over a bigger part of the muscle to innervate. And so that's kind of the recovery process. And the thoughts are either there's reactivation of polio, because they have been able to isolate polio in some patients, but not all, or this is some sort of autoimmune reaction that's causing an attack of the body, or the most likely is this idea of metabolic fatigue of these remaining motor neuron units, which is that over time, it's sort of like, I think of it as kind of like Audrey in Little Shop of Horrors. It gets so big that the body just can't sustain it in terms of what it needs metabolically to keep maintaining the function of the nerves, of the muscles, but nobody really knows for sure. And so I think that just leads to some, major concerns in terms of understanding. We know there are long-term consequences of viruses outside of just polio, and probably the best known one is varicella and herpes, right? This is a clear reactivation of the virus. And so this is one where we know it's still lurking in the body and causes zoster. But there's other more complicated ones, such as recent sort of proof, I put in quotation marks, that Epstein-Barr virus is associated with multiple sclerosis. This was a science paper that just came out last year showing pretty good relationship between the two, and yet, obviously complicated in terms of how is EBV sparking multiple sclerosis or causing an increased risk of it, and nobody fully knows. And so to me, this leads to some pretty scary worries for COVID-19, because I'm actually not talking about long COVID. To me, long COVID is in some ways closer to the residual paralysis that you got from from polio, right? It's sort of the ongoing sequelae of the initial infection. And the hope is that over time, both the paralysis would improve and people would get strength back, and long COVID, we hope people will improve. But really this idea of something that could occur that we don't even understand yet what might be triggered in terms of like a post-COVID syndrome down the road. And I think, just numbers like this are worrying. Between April and August 2022, 98% of Canadians had antibodies against COVID. A lot of this was from the vaccine, but 54% had antibodies from a previous infection. So we've got this new virus that now has infected everybody. There are some data that some patients with long COVID do have evidence of the virus still in them in terms of fragments of RNA, but viruses are weird things, and we really don't know what 20, 30, 40 years down the road. I mean, we also know there's relationships with cancer and things like that with some of viruses. So that's, I think, a real concern going forward. This is where I think that one of the things we can do is surveillance, right? And I think it's just having vigilance and being aware of what you're looking for. Places like ICES are fantastic because we actually have large scale data on the population in not quite real time, but close to it. So we're not reliant on some very smart clinician recognizing some cluster of cases to spark the idea that maybe there's some relationship going on. We can actually more readily sort of look for patterns like this. And so I think that's going to be really important going forward. And so just to end thinking about the future, I do think we're going to see more infectious diseases, a lot of concerns with things like the war in Ukraine, that multidrug resistant tuberculosis will be increasing. These are data modeling from China, where they're not even without war, just what the forecast looks like, that untreated MDR TB is that blue line, and that will be increasing rapidly over time. And of course, that's going to spill over into ICUs. And then, of course, really scary is climate change and how that will shift the diseases we see and bring about infections that we're not used to seeing in certain regions. This is just one example modeling valley fever cases as the US heats up and it spreads across the United States, and where you would be seeing that. And you can sort of pick your disease, right? Malaria or dengue or whatever you want to choose. And this is likely to be the case. I want to end with this map. This is the map from 1952 that Henry Lassen had in his office. And he had sent out medical students, a team of 6, to track every case in Copenhagen. And he had a pin at the address of that patient so he could try to understand the pattern of polio cases in the city over the course of that epidemic. This map is now in the Medical Museum in Copenhagen, but I think it's important to recognize that, each of these gazillions of pins here is an individual patient. And these are some of their faces. I got to meet all of these patients, polio survivors from the 1952 epidemic. Not all of them had respiratory failure, but all of them battled paralysis after residual paralysis. And actually, unfortunately, every single one of these individuals now has post-polio syndrome in one form or another. We kind of stand on their shoulders in terms of the care we deliver, because very much it is what they went through that sparked our understanding of the things that have led to modern intensive care. And so I'm very grateful to all the patients over the years who have provided their bodies for our research to better care for patients. As mentioned, I have his book that just came out 2 days ago, The Autumn Ghost. It's on back order right now on Amazon, but it should be available for order in most bookstores. And so if this interested you at all, I hope you'll consider reading it. It's written for the general public. And one of my goals with it really was to allow the rest of the world to understand the importance of what it is that all of you do every day. That was an important part of writing this book. So I hope you'll be able to share it with family and friends as well. So I will stop there, and left, I guess, not quite 20 minutes for questions. Apologies, but it was a lot to talk about.
No, Hannah, that was wonderful. It just shows the power of storytelling. And you're right that there was a lot that went into creating our specialty, and the benefit certainly is there. And I guess I've learned now where Dandy Walker syndrome, who that was named after, I presume, Dr. Dandy. And in terms of polio, I must admit I have a very personal interest in this, in that my uncle unfortunately passed away from polio in the 50s. And so I didn't know him, but you certainly see the consequence of losing someone so young. And so I think that just demonstrates the value of what we do every day in critical care. You also made me proud as an anesthesiologist there, and as a drinker as well. I realize there's a lot of value in some of my recreational activities. But my question for you is about SARS, and a lot of good came about from the first SARS epidemic. And I won't steal CCSO's thunder, but in many ways that's why CCSO exists. But are there any lessons or things we did wrong following SARS and Ebola that we probably should learn from so we don't do following COVID?
That's a great question. I don't know whether it's something we've done wrong, but there is, I think, a tendency to lapse back into complacency. And I think we're seeing it now even with COVID, right? That sort of people just want to forget about it. And that's a kind of human instinct to want to just get back to normal. And I think, some people like Rob Fowler seized on the SARS epidemic to recognize we did need to try to be better prepared. And there was some of that went on. But, it does feel like every time there's a new round, we do get caught kind of not quite prepared. And it's always a challenge in critical care because preparation is money and time, and a lot of money. The question of like, well, why don't you just have all these ICU beds on standby for the next big epidemic? And of course, everybody on this call knows exactly why we don't do that. So it is always this tension of what does it mean to be prepared and to be better prepared. But there is some amount of sort of stockpiling and thinking through these sort of algorithms for what will we do if that we haven't been great at doing either after SARS and Ebola. And I think Ebola was sort of particularly unfortunate. I know in the US, for instance, they scrapped like entire ICUs to build one Ebola isolation room. There was this mass panic that you just thought, this makes no sense whatsoever in terms of both care at the regular population level for people without Ebola, but also even in terms of care of Ebola patients, that it just doesn't make sense to be doing it this way. So there were sort of kind of these weird knee-jerk reactions that are understandable, but I don't think were very well thought through, that I hope we can learn from in terms of recognizing that, we can't just have tents out there ready to MASH tents ready to go 24/7 for the next surge, but that we do need to think about how do we deploy such things quicker.
I'm glad that's recorded so we can maybe play that for some people when that comes up. But and likewise, I was amazed at the survival with Ebola. I thought it was 80-90% mortality. So that was enlightening for me to see with advanced care the potential impact that certainly we can make. And
actually, I just want to, before, I think this is important. I know Rob Fowler would want me to make this point that, because he's written about this, that even without advanced care, but just with what we would consider very basic standard medical care, they were able to drop the mortality to about 40%. And so I do think it's important to recognize that, yes, to get to that even lower level requires probably the sort of advanced care we provide. But, he's written sort of impassioned pleas to recognize that if we can just provide better basic care, that alone can make a really big difference to people.
Excellent point. Excellent point. I'm going to go to Josée, and then I'll follow with Bernard, Dr. Lawless, who has joined us. Josée?
Thank you. Thank you, Dave. Thank you, Anna. I think this was presented with passion, and it was so nice to listen to. It was a story. I really liked it, so thank you. I've learned a lot. I would like to thank you also to highlight the parallel that you made between the polio and COVID traumatic experiences of the frontline staff, regardless of who you were. And I think it did hit a chord with a lot of us. So thank you for bringing that up, because yes, we do have a tendency to forget about it, but when we're faced with it, we have all these, emotions that are coming up. So thank you. I think it is important to recognize. For me, I'm interested to see, or your thoughts on the impact of social media and misinformation, and your thoughts on how it impacted, or differently impacted, the polio era and the COVID-19, even from the SARS that we saw in 2003 compared to now. So just interested to hear your thoughts on that.
Yeah, so there's always been misinformation. That's definitely true. And in fact, polio is interesting because there was a lot of misinformation about how it was transmitted and a lot of fear around transmission. And it did take them a long time for all kinds of reasons for scientists to understand that it was oral fecal transmission. But even when the scientists knew, it didn't get passed on well to the public. And so there was, for instance, in Denmark, there was a saying, don't eat the apples, meaning don't eat unwashed apples or apples off the ground. Children were admonished constantly with the idea that somehow this was a potentially causing transmission. There were, if you go back to 1916 epidemic, there was a swat the fly campaign because they were convinced it was flies. They killed 70,000 cats and dogs in New York City that year because they were worried they were transmitting it. So that's, the sort of lack of understanding and fear has always driven a lot of kind of crazy behavior. I think what's very different, though, and to your point about social media, is that there were fewer channels for official information. And overall, there was a lot of trust in government and doctors. I mean, and people would drop their 3-year-old off at the hospital entrance. They didn't necessarily want to do it this way, but that's just the way it worked. They handed over their child to the hospital and got no information. They got to speak with the doctor once during their child's stay there. And so there wasn't very much communication, but when there was communication, it was much more trusted. And so you see this certainly with the uptake of vaccines, right? That as soon as the Salk vaccine, the polio vaccine comes out, everybody's lining up to get it. And we very quickly get to levels that allow for essentially close to eradication of the virus. And even in the United States, there was a horrific incident within a few months of the vaccine coming out called the Cutter incident, where it was a killed vaccine. They killed the virus. And one of the manufacturers did not follow the procedure correctly and sent out a batch that had actually live polio virus in it. And they killed 20 people and paralyzed a couple hundred. Now, you imagine that happening now, like that would be it. Nobody would touch a COVID vaccine if something like that had happened. But remarkably, within a few years, there was a little bit of hesitation, but people kind of got the message that no, this was safe and this was a mistake, and lined their kids up to get the vaccine in the end and hit 90%. By really within a few years. So I do think social media really is the difference. I mean, they were very aware of needing to get out information quickly back then, right? That Lassen in January 1953, so the epidemic still hasn't even finished, and he's publishing in the Lancet about it to try to tell the world about it. And he knew that was one of the best methods he had, because that was a journal that would be read by a lot of people. So dissemination of information was clearly important. It obviously was slower than it is now, but the level of trust, and you can argue the level of trust in Denmark, actually, even with social media, is still pretty close to what it was back then, I would say, relative to North America. Their following guidance of their government during COVID was completely different from the sort of mess that was North America and even much of the rest of Europe. So I guess in that sense, I can't fully blame social media, but certainly I think that makes it more challenging. Once those things sort of do take hold, it can be hard to undo them. So no great answers there, but a lot of kind of interesting history and reflections.
Thank you.
Yeah, I'm worried Elon's going to be kicking in here pretty soon. But social media had benefits, but it also had major downsides. So I think you could spend hours trying to figure out which side did it end up on. Dr. Lawless, I'll pass it over to you.
Great, Hannah, thanks very much. That was I've been receiving messages from people who've been on this webinar, and just fantastic presentation. Like what such a full, rich description of the historical pieces, but if you're even just from the mechanical ventilation alone, the rest of the story that goes with the social component of what people were going through, a great presentation, a depth, I'm sure, of research that a lot of people don't get to scratch very often. So congratulations on that, and thank you for being so thorough on it. Thoroughly enjoyed your presentation. I really thought surgeons had a large part to play in developing ICUs, but Neilipovitz all the time. But
yeah, everybody's got their person they like to bring in.
But I think it's really interesting, especially from, and I guess this is maybe part of the history of medicine and how it's evolved and how things happen. People discover some things sort of not truly happenstance because there's some method or thinking that they had to lead them to that, but even using what they were using in breweries to start doing acid-based testing. I don't think I knew that before, and I think, like, wow, that's fascinating. And there are, like you said, in terms of alluding to Rob, like if we do things really well, so some of the basic things we can do, and if we can do them well, it really goes a long way. And it's not always about the fanciful things that you have to research in a lab for 5 years. Those also contribute, but that if we really focus on the things that we can do well, that it does go a long way. I think just a comment, I think, on preparedness, like how do we prepare for the next thing? And after having sort of been here with SARS and then post-SARS and all the things that we've implemented as a system to see if we could prepare differently, there was a different feeling, I think, of being prepared for COVID, even though I think the thing that is prevalent in people's minds when these things are, getting these reports from across in other countries and how bad it is, that it's fear that makes us feel like we're not prepared, and sometimes makes us forget that we actually have done some things to be better prepared. And I think I'm not sure what the right balance is in being fully prepared or feeling fully prepared, and the mix of then, where do you spend your resources in the time? And that's always the conversation, I think, with dominant decision makers, i.e. where the funding comes from, of how you make that investment for being prepared, whether it's, practicing skill sets, whether it's putting up tents that are going to be your isolation tents, whether it's having enough XYZ on stockpile. It's hard to convince people. I remember going into the fall of 2019, and many ventilators we had in our ventilator stockpile, which was even novel to have a ventilator stockpile, we're probably going to come to the end of the term. We're talking about like replenishing them, and I could recount stories of like, wow, do we really need a ventilator stockpile? No one really had that vision that there was going to be something right around the corner. And when people have to balance sort of like, how much money you spend on ventilators, that some people would say, unless you make sure you tell how we're using them, sitting in a room somewhere not being used. And that's how I remember masks. We had, not we, but the government stockpile had lots of masks that were stockpiled, but found out that at the beginning of the pandemic, we couldn't really use them because they had expired. And I'm like, how does a mask expire? But it was the elastics. And the elastics were, I don't know if anybody's ever owned a garment where an elastic sort of like gets to a bit of its age. And, but they were worried that the masks would actually fall off faces with the elastics not being, and that's hence why we couldn't use them from the stockpile. So there's so many aspects of this that on an outside perspective, sometimes it seems easy to prepare, or it would be easy to prepare, but it's fascinating sometimes trying to go through that process of what did we learn and how do we at least better prepare, or let's not repeat maybe some mistakes that may have been made in the past, or improve on some things that maybe we could have done better. But sometimes I think it's that notion of being able to sit back and say, okay, we're ready, will probably never come.
Yeah, no, I mean, so just a couple quick comments. I don't know if we have to end exactly at 3 o'clock, but yes, I think that, preparedness is always going to be a challenge, like, even if you are trying your best. And the other thing is you're not always sure what you're preparing for, right? And you don't know, like in 1952, I don't think they knew it was going to be polio that was going to be the big thing that hit them, right? There were a lot of other infectious diseases that could also have surged. And so that is one thing. And I think the one real takeaway that is universal in terms of their ability to innovate, there's a lot of kind of coincidences and other things that just happen to happen. But to me, the one important one is different points of view, right? They brought in someone who didn't have the received wisdom about what was going on, who hadn't cared for polio patients, and actually listened to him when he had an idea. And that ability, and I think we've gotten better at that to recognize that you need different voices, you need different backgrounds at the table, you need interdisciplinary teams to be most successful at pretty much everything, but in innovating. And when you are trying to problem solve because you don't know what's around the corner, that you don't want a team where everybody thinks the same. You don't want just infectious disease doctors in the room. You don't want just intensivists in the room. You don't want just nurses in the room. You know, you really want all of those perspectives. And that is one of the biggest takeaways for me from that epidemic that is applicable to everything we do going forward.
Yeah, it's so true. And I think, again, that part becomes, something that plays out frequently, and we can't forget that piece, if that's a vital piece of what we, in the mix of what we need to do preparing going forward. I'll hand it back to Dave.
I think we truly are stronger together, and it's a fitting way to end. Just want to remind people if they can take the time to fill out the survey that's sent. We certainly appreciate that. Hannah, certainly, I think we really enjoyed this. Your book is The Autumn Ghost. We'll give another plug for that.
Thanks. Years of tears and sweat that went into it.
There you go.
If it's a back order for hard copies, you can actually download it electronically. Some people have been telling me that they've done that already.
Oh, yes, it is available for the Kindle. Yes, thank you.
That's technology I don't know how to use. I'm old with that, but I also invite everyone to come to the next one where we're going to flip this, where instead it's the history, it's the future of critical care. And I'm just going to go for closing comments to back to Bernard, and thank you again, Hannah, for a wonderful presentation.
Great. Thanks very much, Dave, and Josée as well, and the CCSO team. Hannah, thanks very much. Everybody, I think, really enjoyed your presentation, and it was it's good to have this sometimes as a encapsulation, I think, of pieces of where we evolved from, and not just all finite sort of clinical elements that we can deliver to people. But this is really good grounding, I think, discussion. We've had you as a presenter before and very much enjoyed it again. So thanks for sharing your wisdom with us.
Thanks for sitting through it. No, thank you so much to all of you for allowing me to share the story and getting to celebrate our kind of rich history with everybody. So
Great.
Take care. Bye-bye.
Thanks, everybody.
Thank you.